Okay, the first specimen is a 88-year-old female. This is a voided urine specimen. She has been diagnosed with upper tract high-grade urothelial carcinoma and have received surgery. So on low power, it is not a very cellular smear. However, we can appreciate they do have some scattered, very dark cells. So when we go to higher power, indeed, this cell does show significant cytologic atypia. So if we can find a relatively normal-looking umbrella cell, these cells definitely show hyperchromasia and with coarse chromatin, irregular nuclear contour. So you can see this is a triangle and have some angulated nucleus and also increase in NC ratio. So we see quite abundant of these type of high-grade urothelial carcinoma cells. So this is diagnostic for high-grade urothelial carcinoma. So despite the relatively low cellularity, we still had a good amount of these highly atypical cells. So this is diagnostic for high-grade urothelial carcinoma. So the next specimen is very uncommon. This is probably the only case I've seen. So this is actually the second specimen from the same patient. So let's take a look of the first specimen. So this is a 76-year-old male, and this is his pleura effusion specimen. So this is the first pleura effusion that we received, and we signed it out as negative. So on low power, it seems to be that there are a lot of these like a high NC ratio cells in the background, in addition to relatively low NC ratio cells. So these cells do looks like mesothelial cells, and you do see intercellular window. So these looks like a mesothelial cells. So we see some quite abundant these mononuclear high NC ratio cell. So at the beginning, I think the original science doctor think this is just lymphocyte. However, if we take a look of these specimen and try to find a relatively normal lymphocytes, for example, such as maybe this one, or not easy to find, but these cells do show a quite monotonous feature, and it is slightly bigger than it should be. And a lot of them do show a prominent nucleoli. Okay, so it's relatively monotonous, and we do see relatively much bigger cells, some smaller cells, but still show some nuclear atypia. So these mononuclear cells are actually not normal. So if we think about like a single cell high NC ratio tumor, I think the first thing that we think about would be lymphoma. However, in the background, we do not see a significant lymphoglandular body. So usually for the lymphoma, we will see small cellular fragments in the background. We do not see that. And additionally, I think these cells still have some cytoplasm in the background. So if we want to determine whether this is lymphoma, usually we would go to Leusten to see if we can see any cytoplasmic basophilic rimming material. So we do not see that, but in the loose stem, we does see these cells show quite monotonous appearance and a lot of lipid droplets in the cytoplasm. So this is kind of unusual because the morphology pattern does have a high suspicions for the lymphoma. So we need to check the patient's past history. So the patient is actually a victim of NOT carcinoma of sinonasal tract. So NOT carcinoma is a very uncommon tumor. So in the old time, it was called NOT Milan carcinoma, but nowadays we know that it can occur not only in the midline, but as well as like a lateral, like a one side of the body. Additionally, in the old time, this is associated with a young, like a very young age, but nowadays we know it can occur in an old patient. So the patient is 76, so very old. So this is his second specimen. So I received this second specimen, and these show very similar morphologic pattern to the prior specimen, and we have tons of these monotonous high NC ratio cells. Again, these looks like a small round cell, a little bit primitive, and like quite abundant in the background. So at this time, we do have a cell block. So abundant cells. So NOT carcinoma usually we have a squamous phenotype. So this is P40. So P40 is diffusely positive, and you can see there were some mesothelial cell that is negative. I also do a CK, but I just want to show you that CK is definitely not a good marker in body fluid cytology because it will be positive for mesothelial cells. So what we see now, all these strong standing cells are actually mesothelial cells. These are not the tumor cells. So the tumor cells are in the background, showing these very weak, like a dot-like standing in the cytoplasm. So these are the tumor cells. The strong standing cells are mesothelial cells. So because it is a NOT carcinoma, the most important stain would be a NOT stain. For the NOT carcinoma, it will show strong nuclear expression in the nucleus. So you can see all these smaller cells are positive for NOT, but the bigger cells, these are mesothelial cells, so they are negative for NOT. So this is the first case that I've seen that NOT carcinoma with pleural effusion metastasis, and we missed the first specimen, but for the second specimen, we are able to identify this. So this is relatively uncommon, and I have to say on low power it is a little bit difficult, but the most important thing is that you find these relatively monotonous appearance, and when you go to high power, you need to determine whether these are lymphocyte. If you think this is lymphocyte, this is definitely show too much cytological TPS, it's too big, and most of them do show small nucleoli, and this is also not normal in a reactive lymphocytic background. So these are all malignant. So these are all not carcinoma metastasis. So the second specimen coming from a 50-year-old female. So this is a patient, a new patient to our hospital, but she does have a past history of breast cancer. So this is a pleural effusion specimen, and the cytospin is suboptimal because we see significant drying artifact, so make it quite difficult to interpret. So I think we can identify some typical cells in the background, but in a preparation like this is very difficult for us to definitely call whether these are a true metastatic tumor or not. Luckily, we do have a cell block preparation. For the cell block preparation, we start to identify some cluster of cells does show cytologic atypia, including hyperchromasia. And we also see this cell-in-cell type of pattern. So this is relatively abnormal, and this is actually quite common in the breast cancer to see this cell-in-cell type of pattern. So because this is a new patient in our hospital, despite prior history of breast cancer, we would do a stem for her. Additionally, we also see these Indian file patterns. See, this is an Indian file. So it does have classic cytomorphology for breast cancer. And this is a patient of triple-negative breast cancer. So originally, in the review of pathology slides, they do a new marker called TRPS1. This is more sensitive for triple-negative breast cancer. So we do TRPS1. This is positive in the nucleus, so suggests that these are tumor cells. And we do see similar morphology with cells and in cell pattern. So I also do a GATA3, just want to check whether these would be still positive for GATA3. So GATA3 is still a good marker for breast cancer. So these are strongly positive in the cytoplasm. So we can see Indian fire, we can see some cluster. We can also see cell-in-cell pattern highlighted by the immunohistochemistry. So this is indeed a breast cancer. So because we have new cytotech training, I think recently the cytospin indeed is not optimal. So we need to be more careful with the cytospin preparation. So the next specimen is a 55-year-old female. She came to our hospital due to bilateral ovarian mass and with peritoneal, ruled out to have peritoneal involvement. So the patient came to our hospital for gynecologic surgery. So she's not very old, 55-year-old. So she received radical hysterectomy plus bilateral oophorectomy. And this is a washing cytology specimen. So first of all, there is an interesting finding that we will occasionally see in the PURA, in the peritoneal washing cytology, which is hyaline globule. So this is a collagen globule, was present because of the washing force. So all these lining cells are actually mesothelial cells. So this is relatively uncommon, but occasionally you can see a peritoneal washing cytology present with this type of hyaline globule. So do not interpret these as a metastatic adenocarcinoma. So these are all peritoneal, like a mesothelial lining cells. So because we do see quite abundant hyaline globule, we know that this is a washing cytology specimen. Additionally, we also see these flattened sheets of mesothelial cells. So we know this is likely washing. It is not ascites. This is a washing cytology specimen. So for this specimen, at the beginning, I have to say it's kind of difficult because for the ovarian cancer, it is more common that we will see high-grade adenocarcinoma. And so they were some clusters showing this relatively higher NC ratio, but quite monotonous appearance and three-dimensional. So I have a difficult time to determine whether this is a mesothelial cell or these can be metastatic carcinoma. So this is the problem for body fluid cytology. So usually we will look for second population, but if it is a washing cytology, usually it will cause some artifacts. So usually for the peritoneum washing cytology, they won't order a cell block, but for some reason for this case, they do order a cell block. So in this cell block preparation, we do see some aggregates of the cells. So with a relatively hyperchromatic nucleus, and we do see these like a smaller cluster, but it is a little bit uncertain whether these are mesothelial cell or not. I think these are indeed mesothelial cell because we do see intercellular window. So when we review these slides, I find some relatively unusual finding, which is again cell-in-cell pattern, cell-in-cell pattern. Additionally, I also find some area showing Indian fire pattern. But this is the hyaline globule that was shown in the pap smear as well. So these are all mesothelial cells, right? And we do see occasional cells with more hyperchromatic nucleus and the Indian fire pattern. So this is a very good Indian fire over here. See? So what does the cytomorphology tell us? This might be a cucumber tumor, that the patient is actually a breast cancer patient, and the clinician still think she is a patient of ovarian cancer. So this is GATA3. So you see all these small, like a ball cluster of cells, these are benign. These are mesothelial cells. Okay, and these, so they are much more than we expected because it's very difficult to tell which cell are truly cancer cells. But yeah, indeed, we can see this is Indian fire, right? So cytomorphology does matter. So we know much earlier than the clinician that the patient is a breast cancer patient. So I already told the clinician that he should check the breast, and all these larger chunk like looks like carcinoma cell are actually sheets of mesothelial cells. So it's relatively difficult. This is a difficult case. But we do identify features that were uncommon in the ovarian cancer. This is the Indian fire pattern, you see? Okay, so this is coming from the breast, not from the ovary. And this is a cucumber tumor, not the ovarian cancer. So next, also, the patient had a history of breast cancer. So I don't know why, but the cytospin for these couple days is very difficult to confirm whether these are true tumor cells or not. So we always need to have immunostain. So for this case, I have to say I do have a difficult time to identify whether any of these individual cells are true breast cancer cell or not. But again, I think we can all agree that some of the cells does shows very big nucleus and quite prominent nucleoli. It is looking like much bigger than it should be for the usual mesothelial cells. So if this binucleation cell is a reactive mesothelial cells, I think this cell does have a relatively irregular nuclear membrane, and the size of the cells are actually quite big. It's very big, but I have difficulty whether these are mesothelial cell or not, because this cell does looks a little bit similar to these cells, but these cells looks quite atypical. So for the case like this, we also do a GATA3. Yeah, so for the GATA3, again, we see a lot of these individual cells in the background, and much more than we expected. So again, for this patient, it does has metastatic breast cancer with this poorly differentiated morphology. The patient actually had a ductal cancer, not a lobular cancer. So difficult case. So usually breast cancer is not that difficult because we will see cannonball, we will see Indian fire, we will see cell-in-cell pattern. The more difficult one will be the gastric cancer. So this is a patient with a history of gastric cancer. So again, I think the cytospin is a little bit like a suboptimal. But we can appreciate they do show highly atypical cells with quite bubbly cytoplasm, quite prominent nucleoli scattered in these very like a lymphocytic specimen. So it does show like a feature of adenocarcinoma. And here we do see there is an intracytoplasmic mucin vacuole pushing the atypical nucleus away. So this is positive for adenocarcinoma. And for the MOC 31, which is a glandular marker, also highlight positive cells in a membranous pattern. So this is positive for adenocarcinoma and compatible with the patient's past history of gastric cancer. So another patient with history of gastric cancer. So in this specimen, we do see relatively like unusual for the gastric cancer is that we do see tight aggregates with a luminal border. So I think the patient actually had a mixed intestinal type and the signaling cell carcinoma, because we can also see signaling cell in the specimen, but also a very tight, like a tubular glandular structure in the specimen. So the patient is actually had the both histo subtype. So in the cell block preparation, it is quite clear that it does show very prominent like a glandular structure. So this is definitely a more intestinal type looking fragment. But in the background, we do have individual cells with high-grade atypia with prominent signaling cell feature. So this is actually a patient with mixed type gastric adenocarcinoma. So this is also positive. So next patient, this is an ascites specimen. So for this ascites specimen, we see like a smear of these larger fragments of cells. And when we go to high power, this cell does show unequivocal cytologic atypia. So with vesicular chromatin pattern and arranged in like a irregular glandular type of sheets. So the patient had a history of cholangiocarcinoma. So these larger cells suggest it's high grade, but it still have this like a tubular structure. So this is consistent with cholangiocarcinoma metastasized to the ascites. So because we received these specimen on Monday, so likely the specimen has been pool rested during the weekend. So you can appreciate that for the cell block, it almost looks like a tissue biopsy because all the tumor cells, along with the normal component, were sink down at the bottom of the tube and then clot together and creating these like a nice cell block. So you can see this is positive for adenocarcinoma. So finally, we have some pap smear. So the first patient is a 41-year-old female, so very young. So on low power, she is young, but we do not see any superficial cells. And we also do not see intermediate cells. We only see these like a larger fragments of cells, and the background seems to be a little bit dirty, right? So this is a quite abnormal background because we do not see any normal component for this smear. So if we go to high power, so this is actually a glandular structure, right? This is a honeycombing sheets, but unlike the usual honeycombing, you can appreciate the distance between each nucleus is kind of irregular. Some are very close, attaching to each other. Some are a little bit apart. Some are overlapping with each other. So this is what we call a drunken honeycombing. So irregular honeycombing pattern. So additionally, we also appreciate the chromatin pattern of these cells are more like a ground glass or vesicular. And we do see small nucleoli. 听懂吗？是什么？好，那你寄回来，谢谢。Frozen. So, okay, so so this looks like quite a typical glandular fragment, and it almost looks like a well-differentiated adenocarcinoma. So throughout the entire specimen, this is the major component that we see. So this fragment is much more atypical, and we do see significant polymorphism. So we have big nucleus, smaller nucleus, we have mitosis. And the most important thing for this specimen, you can appreciate all these cells are very well preserved, very well fixed. So which means that this smear directly sample these cancer cell. So which means that we do have a cancer at the cervix, okay? So the patient also ordered a HPV test here, and we already reported as negative. So with a morphology like this, so we need to think about the possibility of HPV negative adenocarcinoma. And so I think for this case, there were two possibilities. The first is it is a gastric type adenocarcinoma of endocervix. The second possibility is that it is an adenocarcinoma of the endometrium, but with direct cervix invasion. However, usually for the endometrial adenocarcinoma, we will expect to see a more prominent debris-like endometrium like a background. But in this case, we do not see endometrium background. And additionally, I think some of the cells does show quite a prominent mucinous feature. So we do see some extracellular mucin here and there. And yeah, I think this cell, if I don't tell you the location, this morphology does looks like a pancreatic type or like a foveolar type of the mucosa, and you can appreciate there are some mucin here. And by image study, in the MRI, it shows multilocular cystic mass in the lower uterine segment. So by the image finding, it is also compatible with a gastric type adenocarcinoma. So very unfortunate for this patient, only 41-year-old, 1 year younger than me. And yeah, so it tells us that primary HPV testing can be sometimes problematic, particularly for these HPV negative adenocarcinoma. The next patient is an old patient, 77-year-old. She has a history of CIN lesion and received hysterectomy last year. And during the follow-up, so this is the follow-up smear. So this is a vagina smear. This is not a cervical smear because the patient already received surgery, but we can still identify features of low CO. So the patient also received HPV testing, but it turned out to be negative again. So occasionally you will have like a discrepancy between your HPV testing and your pap smear. So for this case, this definitely looks like HPV related, and this looks like a low CO, but for some reason they didn't have the virus in the HPV testing. So for this patient, we will still call low CO.
Could it be, doctor, HPV positive but not the more frequently typed?
Yeah,
HPV?
it's possible, but remember the patient does has a CO lesion, already developed high CO, I think, not have done the surgery in our hospital. Yeah. So occasionally something happens. I don't know how to explain this. So this is also a kind of difficult case. 71-year-old female. So old, so already past the screening age, but still she was followed up because she had a positive P16, a positive HPV16, and the positive pap smear before. So the last time we called this low CO, but for this time I think the cells are just, yeah, it looks almost like a squamous cell carcinoma. But this is an old patient. We need to remember sometimes in the atrophy patient, you can have some feature looking like this. But this is definitely not good, I think. So this is a very small focus, and I think we do have unequivocal area suggest that there is a dysplasia likely related to HPV. I don't know how to explain for all these necky nuclears throughout the entire specimen, but these can happen in atrophy. But these can, I mean, if this is SCC, that's kind of weird, but I think it's possibly due to atrophy. But indeed, we do have a cell showing definite morphologic feature of low CO, so at least we can call these low CO. But with a more suspicious feature, and the patient has positive HPV type 16. So I think we need to call this case dysplasia cannot exclude high CO because we see quite worrisome feature. Yeah, so sometimes we will have very old patient but still with positive pap smear. So that's all the case for today. Thank you.
Thank you, sir.